Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, we are discussing management of chronic hepatitis C. In the previous videos, we have discussed the structure of hepatitis C virus, the life cycle of hepatitis C virus, and different treatment options available. In today's video, we shall discuss how to approach a patient with chronic hepatitis C and how to select the treatment options and what should be done before starting the treatment, what monitoring is required when the patient is on treatment, and once the treatment is completed, what we should do then. So as I said, today we are discussing the towards hepatitis C treatment. By and large, the treatment of hepatitis C has three main components. Before starting the patient on antiviral treatment, what we should do. Then when the patient is on antiviral treatment, then what we should do then. And once the treatment is completed, what's the follow-up and how we should follow up these patients. So taking the first component, that the pre-antiviral treatment approach should be what? When a patient comes to us with HCV positive, there are three treatment scenarios are possible. The patient has been found to be anti-HCV positive, whether the patient was giving blood, donating blood, or it was some pre-visa screening or pre-op screening, and the patient was found to be anti-HCV positive. Or the patient was treated for HCV in past, and now the PCR is positive again. This may be another scenario. That patient says that I was treated for hepatitis C a year ago or a couple of years ago, and my PCR was negative, but I have done my PCR and it is positive. Or I don't know what was the response at that time, but when I have checked, my PCR is positive. So this is the second scenario. And the third scenario is that you have given the treatment, the patient has completed the treatment, and patient has come and his PCR is still positive. So if I summarize again, so the first scenario is for treatment naive patients, possibly. So the patient is anti-HCV positive, the patient may be spontaneously recovered case, or patient may be viremic and the PCR may be positive, and you would like to start the patient on treatment. The second category is those who were treated for hepatitis C in past, and they didn't know that what was the response, or they had responded, but no, the PCR is again positive. So the second group is that who are either non-responders or relapsers or reinfection. And the third category, a third scenario, is the one where the treatment is completed but patient has not responded, PCR is still positive. So the pre-treatment approach depends upon that which scenario, which category we are dealing with. So first take the first scenario, that is a patient has been found to be anti-HCV positive. So what will you do next? Of course, you will check the PCR, whether the patient is PCR positive or negative, whether the patient is spontaneously recovered case or the patient needs treatment. Of course, you will do the liver assessment, whether the patient's liver is normal, insignificant fibrosis, or the significant fibrosis. I have shared a couple of videos on this with you. And clinically, these are the clinical examination, the ultrasound, the APRI-FIB scoring, and if possible, the fibroscan elastography. And of course, you do the general assessment. What is the general health of this patient, whether the patient will be able to tolerate the antiviral treatment. And of course, if there is any concomitant diseases, you check those, and the drugs patient is using for those concomitant drugs because of the possible drug-to-drug interactions. And of course, if the patient is pregnant or the patient is having lactation, so in that case also you check these patients for the status in the married lady, that if the patient is pregnant or patient is lactating mother. And of course, the patient counseling is very, very important, that you patient understand that what's my problem and why the treatment is important. The quantitative PCR and genotyping, simply it is not required, because now we are having the pain genotypic drugs and the viral load does not matter. Does this patient need HCV therapy? Yes, everyone with positive PCR must be treated. This is the statement. Everyone with positive PCR must be treated, except if the antiviral treatment is contraindicated, or if the antiviral treatment is not tolerated, there is poor life expectancy. Believe me, I have a lady with me, and the patient was non-tolerating the interferon. Then when the soft raba came, we tried, patient not even with two drugs, patient couldn't, two tablets, patient couldn't tolerate. Patient couldn't tolerate the soft DECLA, and no, patient couldn't tolerate even the soft well. So there may be patients who are unable to tolerate the antiviral treatment. These are the conditions when you will not give patient treatment. Otherwise, each and every patient with positive PCR must be treated. Okay, how to assess the liver status? One is the clinical features of cirrhosis if they are present. Second, you do the ultrasound to look for the features of cirrhosis and portal hypertension, and non-invasive tests where the ultrasound is also normal, there is no clinical features, and these include EPRI, FIB4, platelet count, and FibroScan stiffness, and you decide whether the EPRI value is more than 1.5 or less than 1.5, FIB4 more than 3.25, less than 3.25, platelet count less than 150 or more than 150, and whether the FibroScan stiffness is there or not. So, and how much is the FibroScan stiffness. So these are the non-invasive tests to look for the liver cirrhosis. And this is with the help of these, we divide the liver status into whether the patient's liver without fibrosis or fibrotic liver or cirrhotic liver. This is the clinical features. When there is, in the case of normal liver, there will be no features of cirrhosis. The ultrasound will be normal. EPRI and FIB4 and the FibroScan values will be these ones. And no, this is the green group, and the patient's liver is normal. And if the patient is a cirrhosis, of course, there will be clinical features, the ultrasound findings will be there, and the EPRI, FIB4, and the FibroScan values will be high. And in between, in the fibrotic liver, there will be no features of clinical fibrocirrhosis. Ultrasound will be normal, but when we check the EPRI, FIB4, and FibroScan, these are the values, and if the values lies between these two ends, then this is a patient with fibrosis or non-cirrhotic chronic liver disease. This is very important that we should assess the liver status, because in the last video I discussed with you that depending upon the fibrosis, we select the antiviral drugs regimes and the duration. So general assessment within 3 to 6 months, if the patient's complete blood count is available, liver function test is available, renal function tests are available, the HBS antigen must be checked, and vaccinate these patients for hepatitis B. And of course, if there is a chance that the patient may be pregnant, the pregnancy test should be done. So if these tests are available within 3 to 6 months, it's okay. Otherwise, you need to repeat these tests, know the general assessment of these very patients. And the concomitant diseases and drugs, what are the current diseases, what are the and what drugs they are being used, they are using for their diseases, are they are using any over-the-counter drugs or not, and are they are using any herbal or dietary supplements or not. This is very important to know. And of course, the potential drug-drug interaction assessment should be done, and there are the websites, now there are the good tables available online, and they can be checked if they're using drugs, whether there's possible drug-drug interaction or not. Education and counseling is very important before starting the patients. When it's treatment naive and you want to start the patient on treatment, the proper taking of the drugs is very important. You educate, counsel them on the adherence with the drugs, And this is very, very important. Our patients do parhez, so they should not be doing any sorts of parhez. And avoidance of the alcohol is very important. And of course, prevention of conception during the treatment is advised. And of course, the prevention of free infection. This is once the treatment will be completed, so they should avoid, they should change their behavior. And if there is any risky behavior, they should change that to prevent the reinfection. So this was the first scenario when the patient was found to be anti-HCV positive and the patient came to you, and this was the pre-antiviral, pre-AVT workup required for that patient. If a patient, it's the second category, that the patient was treated for HCV in past and now the PCR is positive again. It may be a relapser, it may be a reinfection, or it may be even non-responder and the patient didn't know at that time. So what to do here is a pre-op option, a pre-antiviral treatment option. You will ask about number of therapies, how many therapies the patient has received, whether the patient used one therapy, or patient received standard interferon followed by pegylated interferon, then followed by the soft riba combination or soft dacla combination, or what combination, how many therapies, and whether the patients had completed the therapy or not. Sometimes we prescribe them the antiviral treatment and they don't take the treatment for the proper duration and they leave the treatment in before completion. So it should be, you should take the clear information that how many times the therapy has been advised and they have taken, what type of therapy they have taken, what was the duration of therapy they took, and whether they were adhering with the therapy, whether they were taking the therapy regularly or not. This is very, very important. And what generic name of the drug. So I've seen that even with the good molecules, the generic or the manufacturing pharma does matter, and a drug may be some sorts of low quality or poor bioavailability. So this is very important. And of course, if the response was checked during therapy, this is again, especially it was important for the interferon, whether the response was checked during therapy or not. Now with the available DAAs, we rarely check response during the therapy. We check response at the end of the therapy and after the antiviral treatment. And of course, what was the response after the treatment? This is very important. And again, to emphasize that this is very important, then we should be clear that what is the liver status of this very patient as well. Now coming to the third scenario, this is the pre-AVT workup. And if the patient has completed the HCV therapy, but PCR is still positive, what to do in such patients? This is very important that whether before this recent antiviral treatment, whether the patient was treatment naive or treatment experienced, and what type of therapy the patient has completed, how much duration the patient has completed the therapy, whether the patient was adhere with the therapy or not, and what was the generic name of this drug. This is very important. Sometimes we prescribe the patient antiviral treatment. The patient comes after 3 months or 4 months, and patient says, my PCR is not negative, it's still positive. And when we ask, either they have taken the suboptimal dosages drugs, or they were not compliant with the therapy, or they just took the therapy for a month or so. So this is very, very important. And you should ask the details of the therapy, taking therapy type and duration. And of course, if response was checked at any time between the therapy. And this is again important that if not known before, please assess their liver status, whether it's in the liver without fibrosis or fibrotic liver or cirrhotic liver. So coming to the HCV therapy, it's genotype specific and pain genotypic. Nowadays, we are giving the pain genotypic therapy. So after the pre-antiviral treatment assessments, whether the patient was the first time found to be HCV positive, or the patient was treated in past and now again the PCR is positive, or the patient recently completed the antiviral treatment and not responded, or relapsers. So we assess that, we are clear what type of patient we have, and we have done the relevant workup. Now coming to the antiviral treatment option, I shared with you, I discussed this with you in the previous video, that it depends upon the treatment options, depends upon whether our patient is having normal liver and treatment naive, are normal liver and treatment experienced, are fibrotic and cirrhotic liver and treatment naive, and fibrotic or cirrhotic liver and treatment experienced. We put the patient into these 4 groups. The green is the most easy to treat, the red is the most difficult to treat, and then the yellow, and then the orange. So we go like this, that this is the most easy, this is a bit difficult, this is more difficult, this is the most difficult. And depending upon what we drugs are giving, whether the soft DECLA, the soft well, the GP is not available here in Pakistan, so it is the soft DECLA. So depending upon the grouping in the most easy group, soft DECLA for 12 weeks is sufficient. In the second, when the treatment experienced in normal liver, soft DECLA RIBA for 12 weeks should be given, and the fibrotic cirrhotic liver with a treatment naive soft DECLA RIBA for 24 weeks. But if the patient is treatment experienced as well as fibrotic and cirrhotic, then this is not an option. Please go for the soft well. So coming to the soft well, for the normal liver treatment, I use soft well for 12 weeks. For treatment experience, soft well RIBA, I do use soft well RIBA. RIBA, I add to it and I give it for 12 weeks. For fibrotic and cirrhotic liver, soft well RIBA for 12 weeks. For this, the most difficult group, soft well RIBA for 12 weeks, but may be extended to 24 weeks. This is all what I use. And sometimes when the patient is RIBA intolerant, then I give these patients the soft well for 24 weeks. If it is going to be the GP at any time, then the GP for the most easy group is for 8 weeks, for 12 weeks, for 12 weeks, and here for 16 weeks. I'm using the soft well Voxy only when the patient is a non-responder to the soft well or soft well. Then I go for the soft well Voxy, and the duration is 12 weeks. So on treatment monitoring is very important. Once you start the patient on treatment, inform patient that taking diabetes medication for potential symptomatic hypoglycemia. Indeed, inform patient who are taking warfarin to change the anticoagulation status. This is very, very important. And no laboratory monitoring is required for other patients. They don't need to be monitored as we were monitoring these patients when we were treating them with interferon in RIBA. And of course, whenever they need some help, we should be available either online or physically. Now coming to the third component, that is the post antiviral treatment, how to go about. I must re-emphasize that the goal of the antiviral treatment is to eradicate HCV infection as defined by the SVR, to stop chronic inflammatory process initiated by the HCV infection in the non-cirrhotic patients, end the process of fibrosis and thus minimize the chances of cirrhosis, and if the patient is fibrotic or cirrhotic, to halt or slow down the worsening of the process of cirrhosis, to minimize the risk of development of HCC, and to reduce all-cause and liver-related mortality. Keeping this goal in mind, in view, the treatment, giving treatment does not end the story. It depends upon what is our patient status. So the post-treatment follow-ups depend upon whether my patient is cured or patient has failed to cure. This is another, whether SVR has been achieved or SVR has not been achieved. And again, when my patient has got normal liver or fibrotic and cirrhotic liver. So if my patient has been cured, has achieved the SVR, and the patient is normal liver, again, this patient is divided into low risk and high risk. And if the patient is cured, SVR is achieved, but the patient liver is fibrotic or cirrhotic, then this is a yellow, this is some risky patient. And when the patient has not achieved the SVR, and even with a normal liver, this is a high risk patient and needs its proper follow-ups. But if the patient has failed to achieve SVR and the patient is fibrotic or cirrhotic liver, this is the most alarming source of group, and they need proper follow-ups. So for the follow-up, I will divide my patients into these 3 groups. One is the green group, where the SVR is achieved and the liver is normal, but still here they may be at low risk and high risk patients. Then the cured but fibrotic liver or SVR not achieved with normal liver, these are the moderately risky patients and needs follow-ups. And if the patient has not achieved the SVR and the liver is fibrotic or cirrhotic, this is the most dangerous or risky group and needs proper follow-ups. No, take this group when the patient has achieved the SVR and the liver is normal. How to go about? What should be the post-treatment follow-ups? In the low risk, this is what I told you. In this low risk, SVR 12 or 24, you check the PCR 3 months after the end of therapy or 24 weeks after the end of therapy. And if the patient is achieved, it's okay. No further follow-up is required in this patient. But if the patient is a bit high risk, his behavior or his metabolic status, like the patient is obese or type 2 diabetes, in this patients, what you do, and if there is a history of excessive alcohol drinking, so in this patients, follow-ups are required. So in the low risk, just check the SVR 12 or 24 and no further monitoring is important. But if this is a metabolic patient, metabolic syndrome or other risky behaviors, then these patients needs follow-ups and they should be kept on the follow-ups. Coming to this category, the patient has achieved the SVR, but the liver is fibrotic or cirrhotic. This is a yellow group. So what we do here, lifelong follow-ups are required in these patients for the HCC, for the esophageal viruses, as well as for the HCV reinfection. We have seen that HCV reinfection are at times maybe relapse is found here. So they should be lifelong follow-ups should be made. Surveillance for HCC, how we do that? Every 6 months by means of the ultrasound and serum alpha-fetoprotein, and the risk of de novo or incidental HCC is reduced but not abolished by SVR. Remember this. Therefore, these patients must be kept on surveillance for the HCC. Surveillance for esophageal varices. If varices were present at pre-treatment endoscopy, then 6 to 12 monthly endoscopy is important. But if the varices were not present at pre-treatment endoscopy, then annual monitoring of platelet counts and transit elastography assessment is sufficient, and start into 6 to 12 monthly endoscopy if the platelet count falls below 150,000 or if the elastography increases to more than 20 kilopascals. So this is the way how we follow up these patients for this surveillance of the esophageal varices. For the HCV reinfection, the risk of reinfection should be emphasized to patient at risk, and behavioral modifications should be positively reinforced. Patient at risk should be monitored for reinfection, and treatment should be offered without stigma and delay to those patients who are reinfected, and monitoring of the HCV reinfection through biannual or at least annual HCV RNA assessment should be undertaken. Now, another yellow group, that is the SVR not achieved, but the liver is normal, but still they are at the yellow group. So what do non-invasive methods for staging fibrosis at intervals of 1 to 2 years is very important, because the virus is active and the liver is normal today, but the fibrosis may happen. And so therefore the non-invasive method for staging the fibrosis is important. And what are these? These are the APRI, these are the FIB4, these are the transit elastography. Now, coming to the most alarming or the dangerous group when the SVR is not achieved and the patient liver is fibrotic or cirrhotic. How to do that in this patients? This group, the lifelong follow-up is again required for the HCC, for esophageal varices, and I've discussed with you that how these patients should be followed up for the HCC and for the esophageal varices. So the take-home points of the post-antiviral treatment follow-up is that it depends upon the outcome of the antiviral treatment, whether the SVR has achieved or not achieved, and also whether what is the patient's liver status, afibrotic, fibrotic, or cirrhotic. This is very, very important. Progression of fibrosis should be monitored in case of F0, F1, especially in case of uncured patients, and surveillance for HCC and esophageal varices are mandatory in case of F2, F3, F4, irrespective of the cure. So, dear colleagues, today we discussed the treatment options approach, the management of these patients, that when the management of the HCV treatment patient falls into 3 stages: the pre-treatment stage, on-treatment stage, and post-treatment stage. The pre-treatment stage depends upon whether the patient has been recently found to be anti-HCV positive? If yes, then what workup should be done? How the infection should be established? How the liver status should be assessed? Whether the patient has got normal liver, fibrotic liver, or cirrhotic liver. And if the patient is a relapser, a non-responders, then in that, again, this is very important to know the details of the previous therapy and what are the possible causes that the patient has not responded. But if the patient had recently completed the antiviral treatment and not response, not issued, then of course this group, again, the patients should be inquired about whether the patient was taking the drugs properly or not. And once you do this all workup and you find out the details of the previous treatment and know the status of the liver, then you embark on the antiviral treatment. And for the antiviral treatment, we divide the patient into 4 main groups. The green and the red, they are at the extremes, and in between is the yellow and the orange. And you then use the soft DECLA or soft well with or without RIBA accordingly. And if the patient is non-responders to soft well, then the soft well Voxy is an option in these patients. Once you complete the patient completes the therapy, then the follow-up is important. Again, for the follow-ups, depends upon whether the patient's SVR has achieved or not, and whether the patient's liver is normal or fibrotic and cirrhotic. The good people and where no follow-up is required is those who have achieved the SVR and who has got the normal liver. And the most risky patient are those where the SVR has not been achieved and their liver is either cirrhotic or fibrotic. Then in between is the yellow group, whether the patient has achieved the SVR but the liver is cirrhotic or fibrotic, or the patient has not achieved the SVR but the liver is normal. These 2 groups, they are in the yellow range, and they need lifelong surveillance for the HCC as well as for the esophageal varices and other worsening of the liver fibrosis and liver cirrhosis. So I stop here, and we meet in another video in the future. Thank you very much. Khuda Hafiz.